Hello guys, welcome back to a new video. That is, we are going to handle trachoma. Okay, etiology, pathogenesis, ocular features, differential diagnosis, complication management, WHO classification and treatment. Okay, first ट्रैकोमा. तो वीडियो को मैं थोड़ा मज़ेदार बनाने की कोशिश करूँगा. ठीक है. ट्रैकोमा इज क्रोनिक केरेटो कंजक्टिवाइटिस. क्रोनिक मीन्स इट इज टेकिंग टाइम. Kerato, cornea, and conjunctiva inflammation. Cornea and conjunctival inflammation. It primarily affects the superficial epithelium of the cornea and conjunctiva simultaneously. Characterized by mixed follicular and papillary response of the conjunctival tissue, pannus formation, cicatrization of the rough appearance, and later stage. Okay, leading cause is preventable. Leading cause, it is one of the leading cause of preventable blindness in the world. Okay, it is preventable blindness. First, coming to etiology, causative organism is Chlamydia trachomatis. Okay, Chlamydia trachomatis by our TRIC. Chlamydia is divided into Chlamydia and Chlamydophila classification, and Chlamydia is divided into two, that is Chlamydia trachomatis and Chlamydia lymphogranulomatis. Okay, Chlamydia trachomatis A, B, BA, and C, that is hyperendemic trachoma, which is transmitted from eye to eye. D and K, it is paratrachoma, that is transmitted from genitals to the eye. Chlamydia lymphogranulomatis L1, L2 and L3, there is lymphogranuloma venerum conjunctivitis. Okay, it's from genitals to the eye. Okay, organism is epitheliotrophic and produces intracytoplasmic inclusion bodies known as Herbert-Stellar Prozac bodies. Okay, intracytoplasmic inclusion bodies, also known as Herbert-Stellar Prozac bodies. Okay, these inclusion bodies are also seen that is a diagnostic. Okay, let me tell you this simple diagram. Okay, first there are extracellular infectious elementary bodies. Extracellular infectious elementary bodies that attaches to the host cell and they form elementary body vesicle. This elementary body after 9 hours converted into reticulate body. That reticulate body after 18 hours undergoes multiplication. That is by binary fission of the reticulate bodies. After development, after 24 hours, the inclusion bodies will burst up and release the elementary bodies outside. Okay, and those elementary bodies infect again. Simple thing. Now coming to the predisposing factors. It is most commonly seen in infancy or childhood, more common in females than in males, more common in Jews than in Negroes, dry climate and weather, socioeconomic status is poor socioeconomic status, and environmental, that is outdoor workers are more prone for trachoma. Okay. Source of infection is endemic zones, that is conjunctival discharge of the affected person. Mode of infection same, direct spread, vector transmission, and material transmission. Direct spread by airborne and waterborne, vector spread by flies, fomites, etc. Material transmission plays an important role, that is contaminated fingers, nurses, contaminated objects, tonometer, etc. Prevalence most commonly in Northern Africa, Middle East and Southeast Asia world. Okay, it is seen in India also. Clinical and pathological features. Clinical features are divided into two phases. One is a phase of active inflammatory trachoma, phase of cicatrization trachoma. Okay, first we will finish phase of active inflammatory trachoma. Okay, इसमें कंजक्टिवल और कॉर्निया बोथ के साइंस दिखते हैं. ठीक है. फेस ऑफ एक्टिव इन्फ्लेमेटरी ट्रकोमा, इट इज सीन इन चाइल्डहुड ड्यू टू एक्टिव क्लेमिडियल इन्फेक्शन. इंक्यूबेशन पीरियड इज 7 to 14 days. Onset of disease is insidious and subacute. Okay, phase of active inflammatory trachoma is seen in childhood. Symptoms seen in active inflammatory trachoma are in absence of secondary infection. You can see mild foreign body sensation, okay, occasional lacrimation, slight sickness of the lids, scanty mucous discharge. Simple things are seen in absence of secondary infection, but in the presence of secondary infection, their symptoms are similar to the acute mucopurulent conjunctivitis. Okay, I have already made a video of acute mucopurulent conjunctivitis or acute bacterial conjunctivitis. Same things are seen. Okay. Now coming to the conjunctival signs seen in active inflammatory trachomatis. Okay, that is congestion of the upper tarsal and the fornicial conjunctiva, and on the conjunctiva follicles are seen. Okay, they look like boiled sago grain follicles. Boiled sago grain follicles seen in upper tarsal conjunctiva. In the upper tarsal conjunctiva and the fornicial conjunctiva most common. Also in the lower fornix also, that is plica semilunaris, caruncular or bulbar conjunctiva. Now coming to the follicles of the pathology of the follicles. Okay. These follicles are nothing but formed due to aggregate of lymphocyte and other cells in the adenoid layer. They are formed due to aggregate of lymphocytes and other cells in the adenoid layer. Lymphocytes and other cells in the adenoid layer. It is divided into three parts: central, cortical, and peripheral. Central, cortical, peripheral. Central, you will see histiocyte, few lymphocytes, and large multinucleated cells that are Leber cells. In the cortical part, you will see zone of lymphocytes showing active proliferation. Lymphocytes are seen in cortical part. Next, peripheral part, you will see blood vessels. Okay, see this diagram. Okay, this is a beautiful diagram drawn by my senior. Okay, in the central part, you will see in central part, you will see three things, that is histiocyte, few lymphocytes, and large multinucleated Leber cells. Histiocytes, lymphocytes, and large nucleated Leber cells. Okay, in the cortical part, you will see lymphocytes, and in the peripheral part, you will see the blood vessels. Okay. three parts: central, cortical, peripheral. Okay, and necrosis is seen in this stage. Next, peripheral part, their blood vessels are seen. Necrosis seen in the later stages. Okay, differentiation from trachoma follicles from the other forms of follicular. Okay, third will be papillary hyperplasia is seen. Papilla red, flat topped raised area, red and velvety appearance. Okay, pathologically. Central core of numerous blood vessels are seen. Papillae and follicles both are seen here. Okay. Papillae are surrounded by the lymphocytes and covered by the hypertrophic epithelium. Now, after conjunctival, what are the corneal signs seen in active inflammatory trachomatis? That is superficial keratitis seen in the upper part. You will see Herbert follicle. Okay, I will show you a picture of Herbert follicle. It is very beautiful. Herbert follicles are present in the limbal area, and histology similar to the conjunctival follicle. Next, there is progressive pannus. Okay, in inflammatory, progressive pannus is seen. Okay, what is progressive pannus? It is here you can see it is a vascularization of the cornea in the superior part. Okay, infiltration of cornea associated with neovascularization in the upper part. Okay, new vessels are formed in the superficial between the epithelium and the Bowman's membrane. Later, the Bowman's membrane is destroyed. Later, pannus is active trachomatis infiltration and vascularization occurs. Okay, shallow corneal ulcer is seen at the advancing edge, may become chronic and indulgent. Okay, this is the picture. Everything is seen here. Okay, see in cases of active inflammatory trachoma on the conjunctiva, you can see follicles. Okay, sago grain appearance, papillary hyperplasia, and follicles are seen in the conjunctiva. Okay, in the cornea, pannus is seen. Okay, and the pannus is progressive pannus, and vascularization is seen, and you will see Herbert follicles. Okay, Herbert follicles. These are seen in active. Now coming to the phase of cicatrizing trachoma. Phase of cicatrizing trachoma seen in middle age due to continued mild grade chronic infection. Okay, mild grade chronic inflammation. It is seen in middle age, and it is type for hypersensitivity reaction, and stage also known as sequelae of the trachoma. Now, phase of cicatrizing trachoma also has two stages. Okay, conjunctival signs are. Here conjunctival signs and corneal cells are present in cicatrization phase. In conjunctival signs, we will see Art's line. Okay, ARLTS, Art's line. This is conjunctival scarring, irregular star-shaped linear scar present on the sulcus subtarsalis. Okay, Art's line is present, and concretions are seen. That is a hard-looking whitish deposits vary from pinpoint to 2 mm in size. Okay, concretions and Art line is seen. Okay, this is conjunctival signs. Okay, here you can see this is the Art line seen in the tarsal conjunctiva. Okay, trachomatous scarring, Art's line. Okay, other signs of conjunctiva in cicatrization stage are formed due to accumulation of dead epithelial cells and incipitated mucus in the depression called glands of Hensley, and other conjunctival sequelae include concretion, xerosis, pseudocyst, symblepharon. Concretions are seen. Okay, concretion, xerosis, pseudocyst, and symblepharon. Corneal signs in cicatrization stage are regressive pannus are seen here. Okay, there progressive was there. Here regressive pannus. Okay, pannus siccus. Vessels extend short distance beyond area of the infiltration. You will see Herbert pits here also. Oval circular pits scar left on the left area. Healing of the Herbert follicles in the limbal area. Okay, Herbert follicles heal and form the Herbert pits. Okay. Corneal opacity is seen on the upper part, mainly in the papillary area, and result of chlamydia trachomatis lesions. Okay, other chlamydia sequelae are chlamydia that is corneal ectasia, corneal xerosis, and total corneal pannus is seen. Okay. Now, what are the lead signs in the cicatrization stage? Lead sign are where was I? Lead sign sequelae trichiasis, entropion, tylosis, ptosis, madrosis, and ankylobropheron. Okay, trichiasis means hairs will get rubbing against the cornea. Entropion means eyelid get inwards. Tylosis means thickening of the lid margin. Ptosis means drooping of the eyelid. Madrosis means loss of eyelashes or eyebrows. Next is ankylobropheron. Okay, lacrimal apparatus sequelae is chronic dacrocystitis and chronic dacroadenitis is seen. Okay, now coming to the grading of classification, most commonly is Fisto classification. Okay, don't read that complication part. Most common classification is Fisto classification, FISTO, that is trichomatous inflammation, follicular, trichomatous inflammation, intense, that is trichomatous scarring, trichomatous trichiasis, and corneal opacity. Okay, FISTO, follicular, intense, scarring, trichiasis, and corneal opacity. Okay, try to remember. Now coming to the diagnosis of trachoma, clinical diagnosis made from typical signs, that is FISTO, FISTO. Laboratory diagnosis is by conjunctival cytology you will do, okay. On conjunctival cytology, you will see on GIMSA staining, polymorphonucleosides, plasma cells and Leber cells are seen, okay. Detection of inclusion bodies. I have already said inclusion bodies means they are nothing but reticulate bodies, okay. That chlamydia trachomatis on host cell, that only, okay, cycle. GIMSA stain, iodine stain and immunofluorescence stain are used. On ELISA, chlamydial antigen can be used, ELISA, PCR, and on chlamydia is yolk sac inoculation can be done, or McCoy culture or tissue culture, okay, for increasing the chlamydia trachomatis cell count. Next is serotype of trick agents, okay. Here chlamydia trachomatis sero or TRIC is seen, okay. You can be detected by microimmunofluorescence, direct monoclonal fluorescent antibody, and microscopy of a conjunctival smear can be done. Differential diagnosis, okay. Differential diagnosis: acute trachoma with follicular hypertrophy, or acute adenoviral with follicular hypertrophy, or epidermal keratoconjunctivitis, okay. I won't read difference, you read by yourself. Now coming to the management part, treatment of trachoma. Treatment of active inflammation, okay. Treatment of active inflammatory stage of trachoma, that is trachomatis follicular and trachomatis intense, okay. You will use antibiotics. Mainstay treatment is use of antibiotics. Systemic is more used than the topical, okay. Effectiveness of systemic is more than the topical. You will use azithromycin 20 mg per kg body weight. Other with women of childbearing age, you will use erythromycin, that is 250 mg 4 times a day, or 500 mg 2 times a day for 15 days. Doxycycline for 100 mg, or tetracycline 1%, or erythromycin 1% eye drops can be used 2 times a day for 6 weeks, okay. Child less than 8 years, pregnancy and breastfeed are contraindicated. Okay, you will use azithromycin, you will use erythromycin, you will use doxycycline, you will use tetracycline, okay. Treatment of cicatrizing state of trachoma is artificial tears, that is 1% carboxymethyl cellulose, okay. There is a dryness of the eyelid. To prevent dryness, you will use 1% carboxymethyl cellulose. Surgical therapy, that is in chronic cicatrizing trachoma, okay. Now, what is the sequelae of cicatrization? For a conjunctival sequelae, concretions, removal of the concretions by hyperendemic needle, or conjunctival xerosis by artificial tears, okay. I already said there are concretion and xerosis is seen, okay, in cicatrization stage. In eyelid sequelae, trichiasis, that is electrolysis, cryolysis, or radiofrequency epilation can be done. Trichiasis means eyelashes are get rub against the cornea, okay. For that, you can do electrolysis, cryolysis, or radiofrequency epilation. Epilation means you will pluck the that inward turned hairs, okay. Then next is bilamellar tarsal resection, and cicatricial entropion, okay. Whatever seen are then, like entropion, trichiasis, you will try to treat that, okay. Next is corneal sequelae. Penetrating keratoplasty can be done for corneal scarring. Keratoprosthesis for blindness with scarring. Okay, next is punctal occlusion and lateral torsorrhaphy for urgent surgery. Okay, urgent to surgery. Prophylaxis is most important. That is safe strategy. Okay, SAFE. Now, what is the safe strategy? You can see here. That is surgery, antibiotic use, facial hygiene, and environmental changes. Okay. When you grow from down to up, primordial, primary, secondary, and tertiary. Okay, this is PSM part. Write whatever you know about that. That is surgery, antibiotic use, facial hygiene, and environmental changes. Now, this is a very beautiful picture of active stage of trachomata. Okay, active stage of trachoma. You can see there is follicles and papillae, both are seen in active stage. There is congestion of the tarsal conjunctiva. Progressive pannus is seen, and Herbert follicles are seen. Okay, progressive pannus and Herbert follicles. Here you can see sago-grain appearance. Very beautiful picture. Next, here you can see progressive pannus, that is neovascularization, and here is the regressive pannus. Okay, here is the downset picture. Next, these are the Herbert pits. Okay, Herbert pits are seen in cicatrization stage, but Herbert follicles are seen in inflammatory stage. That is first stage. Okay. Next, this is trachomatous trichiasis. Means here you can see hair lashes are rubbing against the cornea. Okay, irritation, redness is also seen. Okay, with this, I want to end this trachoma part. Video is lengthy. I hope you enjoyed. I hope you understood. If you like, share, and subscribe. Jai Hind, Jai Bharat. Bye bye. This is Akash GZ.